Okay, so now we're going to start testing for the anterior cruciate ligament. And the anterior travels from the posterior aspect of the femur to the anterior aspect of the tibia and prevents anterior tibial displacement. We're going to start with the anterior drawer test, which has very, very, very good specificity. So if you get a positive anterior drawer, you can be pretty confident that patient's ACL is torn. Now, it doesn't have very good sensitivity, and there are two reasons why. First of all, in this position with the knee flexed to 90 degrees, it's very easy for the patient to contract their hamstrings. So when I try and pull the tibia forward, the patient contracts their hamstrings and prevents that mechanism from happening. So then I end up with a false negative. The other problem in this position is half of patients who tear their ACL also have a meniscal tear. If they tear their meniscus, it's probably in the posterior aspect of the meniscus. And when I try and pull the tibia forward, what happens is over the femoral condyle, that posterior meniscus tear gets stuck and it doesn't allow the tibia to come anteriorly, once again creating a false negative. So for those two reasons, tight hamstrings or increased tone in the hamstrings, tone in the hamstrings and a meniscal pathology can both prevent these tests from being positive. So what you're going to do is, again, you're going to find the joint line with your thumbs and bring your thenar eminences right on either side of the tibial tuberosity. I always give the patient a free hamstring massage because I do want them to relax. My force is up high as I can get on the proximal tibia, and I'm going to be pulling anteriorly in this plane. So it's going to be anterior and a little bit superior. So it's going to look something like this. And it's quick and brisk, and I can feel that abrupt end feel. Okay, so that's good. Yes, the patient wiggles on the table, but you need to make sure that that ligament is intact. So that's the anterior drawer. The next one we're going to do is the lever sign, sometimes called the Lelli test as well. For that, I'm actually going to use a half foam roller. I'm going to have you straighten this knee out for me. I'm going to put this one under your tibia. There we go. So it basically puts the leg in about 20 to 30 degrees of knee flexion, which is the exact same angle you're going to put the knee in when you do a Lachman test. The Lachman test is really the gold standard. What we're going to do here is basically reverse the concept of the Lachmans. With the Lachman, I stabilize the femur and I'm going to pull the tibia anteriorly. Here what I'm going to do is I'm going to stabilize the tibia and I'm going to push the femur posteriorly. So when I push down like this, if the ACL is intact, Matt's heel should come up because I'm not creating that shearing motion. So when I push down here, his heel pops up. That is a negative test. If I push down and his heel doesn't move, that implies that his tibia is sliding anteriorly, and that's a positive test. When this test first came out, it had excellent sensitivity and specificity. Since that, it has been called a little bit into question. This test should not be performed in isolation. However, it can be clustered with your other tests and added to that equation. And I do personally think that this is a nice test to do if your patient has very large hands and you're really struggling with your Lachman test, or the patient's having a hard time relaxing, because all you have to do is come in here and push down. The best planar test for the anterior cruciate ligament is the Lachman's test. There's multiple ways you can do it. As a general rule, its sensitivity and specificity is riding at about 81% right now. If you're having trouble getting the end feel, my suggestion to you is to take their knee into a little bit more extension. In my experience, PT students have bent the knee too much and they're not getting that crisp end feel. So because the ACL stops my tibia from coming anteriorly, that's exactly what I'm going to do to the knee. So I'm going to pick up Matt's leg and I'm going to hold on to the distal femur with my outside hand. My caudal hand is going to grab the tibia, and I usually try and wrap around and kind of, if I can get on the tib tube, I do. And you want to be, they usually say around 20 degrees of flexion, between 20 and 30. I usually bring them down closer to 15. And you have to relax and let me have your leg. And then it's a quick, can you feel that? Mm-hmm. It's just, can you feel that? It's a beautiful stop. Yeah. It's this quick, brisk. Now if I flex them up more, I don't know if you feel it, it's kind of mushy. So there it is. That is the end feel. It's quick and brisk. I can feel his ACL is totally intact. Now as I pull up, I do push down just a little bit with my proximal hand on the femur. Okay? Now, if you're saying, well, Dr. Jill, my hands aren't that big, what can I do? You can do another little trick where you actually use your hip, or excuse me, your distal knee, and you bring it under here, and you're going to stabilize the femur. The problem is he's in a little bit more flexion than I like, and I can just do this quick and brisk pull here. If I wanted to bring him closer to extension, I could put a little towel roll or something under here, block him, and do this anteriorly directed force. I had a better infield with the first one. Option 3 is, I'm going to have you scoot this way on the table a little bit, Matt. You're actually going to hang this leg off. And what you can do is you can use your legs to kind of allow how much flexion you want. I'm going to stabilize his femur just like I would. I'm going to do my Lachman's test with my inside hand on the tibia again. And what I can do is now I have him more supported here, and I can do that quick, brisk pull. And if I'm not getting the angle I need, oh, there it is, I can just bend or straighten a little bit more. So this is another option. The fourth option is to do this, but off the table. So I'm going to have you scoot all the way down, Matt. And I'm actually, to protect your back, I'm going to have you take this leg up. Perfect. You can do the exact same thing off the end of the table. So that's too high for me. So same concept. I can stabilize here. I'm going to hold his femur down, and I'm going to look for that anterior translation of his tibia in about 15 to 20 degrees of knee flexion. So it looks something like this. Okay, oh, there it is. If you can't grab all the way around with your thumb, you can certainly do it like this. Okay, some people like to palpate the joint line as they do it. Oh, there it is. That's a good one. You're intact. Yep. Okay, so you're just going to have to practice a little bit. This is a hard skill to do.